Development was going on, is going on in IT as we see in sequencing. Actually, sequencing is a little bit faster right now than Moore's law. We basically, 4 years ago, introduced the technology based on the progress that happened on the IT side to keep, all the data of an entire enterprise in memory and do the compute jobs in memory in real time. It completely changes the world when it comes to how you use data, how you look at data, how you process data. And 2 years ago we had a meeting together, and we thought about what if we would use that technology also in a setting like this. What if we would give researchers the opportunity to harvest the data that is there, to harvest the information that is hidden in doctor letters, make it available to better find out which patients, we heard it before from Bernd Müller about we better should pay more attention to which patients we put into those clinical trials. Imagine if that information would be available at your fingertips. The whole process of how patients would be selected, how we would be able to go back to patients and suggest treatments to them would be completely different. So in a way, we feel, as you already pointed out, Professor Wiestler, we feel that we can make a contribution here with our technology, and we are very, very happy that we are able to team up and partner to make this happen. So we together developed the NCT Data Warehouse, which is an award-winning initiative. It has been recognized already last year by the White House, US White House, as part of their Big Data Initiative. But these days you can argue whether that's a good thing or not, but it really has been recognized as a really groundbreaking initiative 2 days ago. And I want to congratulate Professor von Kalle. This initiative, what has been done with the NCT Data Warehouse, has been awarded the HANA Innovation Award in the category Social Hero Innovator worldwide. So we just had our global big customer conference in Orlando, and this was awarded, the HANA Innovation Award actually, has been awarded to the NCT and Professor von Kalle. So congratulations also from our perspective here. So there's a check that is coming. Unfortunately, my boss, it's a big check. Was not able to bring it over. It should be donated to a charity organization. NCT is not yet on the list, so maybe an opportunity for next year. That, in short, basically was kind of a brief introduction why SAP is engaged in what we are doing.
Thank you. Otmar, if I understand this concept in the right way, the first thing is human genome sequencing. The second aspect is data management, and third aspect is transferring in cancer treatment. Is that correct?
Yeah, I think it's really a combination of three major sort of fields. One is this entire area of high-throughput genome sequencing. The second one is handling all the data, starting with bioinformatics. Friedrich will talk about that in a second, I'm sure. But also integrating this into the entire wealth of information which we have from cancer patients in a data warehouse or data warehouse. But of course, in the end, it's all about clinical expertise. Yeah. Recruiting the patients, translating the findings into tumor boards, sort of adapting treatments in individualized fashion. And that is, of course, the third major player here, the oncologist. NCT, the medical center here, and all the colleagues involved in recruiting, treating, and monitoring patients.
Mr. von Bohlen, what is the role of dievini in this concept?
Yeah, this is, try to keep it short. Let's, on dievini and what we do, maybe a couple of important points. First of all, as most of you know, dievini is the investment arm of Dietmar Hopp in biotechnology, and we are focusing on a few things only, and maybe I can point them out. The one focus is clearly on, I would say, novel, we call that, we heard that before, first in man in best case, platform technologies in oncology. And we had a very early focus in cancer immunotherapy. That was in 2005, 2006, when people at MD Anderson and also here in Heidelberg almost shot us when you used that. I mean, I was recently in Houston, and Ron Del Pino said if you had mentioned cancer immunotherapy in 2006, you would have been fired. Okay, I was never an employee of MD Anderson, so that was not my problem. The other thing is, what we're discussing here, heard before from Stefan Brock and discussing here before, namely, if you really want to treat targeted, if you want to treat individually, I mean, you need to understand, actually, you need to understand the true Blaupause, if you will, of what you are treating. And this is not so much in the history of other patient treatments. This is in the truth of your molecular predisposition. I mean, I don't need to say that here at the DKFZ, but the genome is a very important source, I mean, definitely, but it's not the only also to say this. So, I mean, whoever believes the genome will solve all these problems, I would disagree. But it's a good first step, and you must not forget, if you want to do that for a broad patient basis in this country, in Germany or in the United States, it needs to be affordable for the individual and for the system. So it has to be payable by the system. I mean, this is a big debate, I can tell you, because the system is not waiting for novel ideas to spend money for. As everyone knows, I mean, the system is waiting for other ways to save money. So, I mean, you have to convince the system, and this is why we run this clinical trial here together with NCT, DKFZ, SAP, and GATC. And I mean, a little anecdote, it was about 14 years ago when I had the privilege, chance, or whatever, honor to present in front of Daniel Vasella, who was the CEO of Novartis, and I told him in a private meeting, I said, there will be the day when Novartis will have to change oncology from an organ-specific medicine or therapy development into a more, mutation-driven system, and he almost fired me out of the room. That maybe was a bit too early and was a bit too provocative, and maybe I'm not completely right, but I wasn't completely wrong at least. And I think everyone here in Heidelberg and elsewhere working on molecular areas will agree. The last thing to mention from Dietmar Hopp, I mean, and you know this, I mean, he has a very, very strong commitment to where he comes from. I mean, we have no single investment in the United States because he says, there are so many people in the United States that have money, why should I invest money in the United States? He wants to invest the money where he made the money, which is here in Germany. So except for two exceptions, which have another background, all the investment companies are here in Germany, and you all know that Germany is not a very splendid biotech area, but that doesn't matter. I think although we had some setbacks, and I'm sure you know more about the setbacks than about the other companies, but I can tell you there are some other companies very well underway. Some things I must not talk about, some things I'm at least convinced of. And then last point here, I think DKFZ, NCT, University Clinical Heidelberg, I mean, this is of course a hotspot for also our academic and translation activities. And it's not only the project that Otmar, you mentioned before, it's also not to forget HiStem. Sure. I mean, this was 6 years ago when I think Otmar, you and others came with this idea, namely to understand the role of stem cells in cancer diagnosis and further treatment. And when we talked to Dietmar Hopp about it, we told him, well, this is a great idea, but probably too early for commercial activity. And I'm convinced it was too early. So what he did was, and he's an entrepreneur, he said, okay, then I support that from our foundation. So the DKFZ and the Dietmar Hopp Stiftung, they raised HiStem, which is a 50-50 joint venture between the DKFZ and the Dietmar Hopp Foundation. And I think what has been achieved in these 6-7 years is fantastic. And I have no doubt that a lot of good things, in particular in oncology, will come out from there as well. Remains to be seen how that looks like, but stem cells, I mean, also to say this, I do not believe that stem cells will cure cancer, as far as I don't believe that any other single approach will cure cancer. But I think the armatory is getting better and better understood. And with that better understanding of the armatory, we're coming closer to at least move it into a chronic possibly later into curative disease.
Yeah, thank you. I think we are all very impressed. Also, Hallek, what are doing the poor people living outside Heidelberg and wants to do oncology?
Yeah, well, in Cologne, yeah. So I wish to reply. I think, first of all, it's good that in times of resource problems in the healthcare system, there are places where larger investments are done for some heavy investments like larger sequencing facilities as an example or so. And so I think there's a good sense of all these things, also concepts for data mining, which German company, if not SAP, and maybe with the DKFZ, should attack this problem in Germany. So I think it's totally reasonable and a very, very good thing to have it here. But if you look at this from a perspective that you find in the United States, I have a very simple answer, and I think that's an important message. You have the NCI, but you also have Harvard, Stanford, you have Yale, and that's our place. We are not Harvard, of course, but there's a place for universities. There must be a place, and Cologne is trying to develop globally practice-changing clinical research in certain indications, and that's something we do. And I think we can team up with Heidelberg on some of these projects. In others, we can do it alone. And this is something which is a normal development, and also Freiburg can do, because in a rapidly changing medical world, this will not be the thing of one place. It will be the effort of many that makes things change. Actually, one of the biggest progresses and advances in medicine in general has been achieved by a pluralistic bottom-up approach, that many creative ideas have come to actually into power and created novel software technologies. This was certainly not, and is still not, a top-down approach by the American government to actually create novel software technologies. It's a very bottom-up approach. And many, many small companies, many actually of the novel inventions in healthcare and novel drugs came from small biotech companies and not from the large pharmaceutical companies as well. And I think in the end you need both. You need the larger investments, and you need the creative, sometimes more flexible, intelligent, smaller universities, and some of them can be Harvard, some of them can be just Wisconsin, but they do very, very good things, and I think that's our place. Now, in practice, I think it is important, however, that to create progress in cancer, we need to create networks so that the structures in a small country like Germany, it's the ideal country to create networks to improve cancer care, because we have a solidaric, relatively well-organized system that is not only business-driven, so that novel ideas can actually spread out faster. And if, let's say, an invention is done in Heidelberg or in Berlin or in Cologne, we can test it together, sometimes faster than any other system would do. And that's actually what we should do in colorectal cancer, as in any other disease. And to close, if you sit in front of a colorectal cancer patient these days that has undergone metastasis, and I just tell you an example that I had 2 weeks ago, every single decision becomes more complex. 4 or 5 years ago, we had 1 or 2 courses of this or that chemotherapy. Right now, we are trying to actually implement sequencing technology in Cologne, not whole genome, but targeted sequencing, and then build therapies with this. And again, this requires clever strategies, and one approach is certainly to create data mining concepts and these big data sets, as you do it here. The other one is to start thinking how we can probably reduce complexity in practice. You can do it either by data mining and computer technology, but we also have to think about less rich regions in the world, including maybe Mecklenburg-Vorpommern, that may not be able to afford sequencing for all patients very soon, and to try to reduce, and that's why we have started a liquid biopsy program to reduce the complexity and to try to answer the question whether we can simply do sequencing efforts from peripheral blood rather than repeated biopsies from tumors, to learn to reduce the how to reduce the complexity in patients. And that is actually starting in GI cancer in Cologne. So that's one of the concrete projects that we are right now doing there.
Thanks. Of course, Freiburg has also his own specifics in oncological research. That's very clear. Really epigenetic, for example. But on the other side, I'm close to Professor Hallek. We need networks, and I think a good basis is the DKFZ.
Sure.
Maybe you want to say something about this?
I think I fully agree with Michael Hallek. The possibility for a country like Germany is joining forces and networking. We will never be able to build an MD Anderson Cancer Center here. Our system is different. Even NCI has a dimension which is just totally different from the DKFZ, for instance. But what we can achieve is intelligent sort of networks and consortia. There is a number of encouraging developments, I feel, some of them promoted by the federal government during the recent years, these German centers for biomedical research, where we try to sort of put together the strongest sites, universities and non-university organizations in the 6 major disease areas, and provide them with an opportunity to receive long-term funding to introduce novel ideas into clinical validation and application in the long run is one possibility. These centers are still quite young, but they are an interesting approach, which the Americans, by the way, would never take. One of these examples is the German Cancer Consortium, which allows the DKFZ to open outstations at 7 German university sites and to set up a very close cooperation with our partners in university medicine at the respective locations. We just had a scientific advisory board meeting yesterday, and it's quite amazing how this network develops and how much enthusiasm it has sort of produced over only 2 years or so. This is the first step. Of course, this cannot be all. You always have to make a selection. It's unfortunate, for instance, that Cologne is not a member of this German Cancer Consortium, and there must be ways to sort of open this up, integrate experts who represent important fields. It may also be necessary at some point to delete some of the partners or exchange them. But the first step has been taken. I think what's also very important for the patients in particular is this movement by the Deutsche Krebshilfe to set up a national system of comprehensive cancer centers, of which Cologne is a prominent member, and Freiburg as well. And this also, I feel, has helped to sort of promote oncology, to promote oncological research, and it has a clear impact on patient care in the colorectal cancer field, but in many other areas as well. One of the challenges, and I think this brings us back to the meeting of today and yesterday, which we certainly are not mastering yet, is to develop new ideas for risk assessment, early detection and prevention of cancer. This area is clearly underdeveloped in Germany and needs strengthening. Colorectal cancer is a very nice example because there's hardly any other cancer which could be so easily avoided using technology which is available today. Colonoscopy, sensitive stool tests, reimbursed by the insurance companies, yet we still haven't managed to roll this out. There's significant improvements, and this would not have been possible without Christa Mahr, but there's more to do, and there's also more research to be done in this particular area of early detection and prevention. So much for the moment.
Yeah, thank you very much. Coming back to the topic of the meeting, prevention and early detection, that was also my plan. We have 15 or 20 minutes more. Mr. van Bohlen, you have heard a lot of speakers and a lot of ideas and a little bit too much Mauses vielleicht. Maybe if you should invest money in one of the ideas you have seen here, which one is the right answer?
Good question.
The good news is, in one of them we are already invested, and two actually. I mean, the one is what Hans-Georg Rammensee presented yesterday. I mean, from his group come two companies, Immatics and CureVac, both in the immunotherapy field. One was peptides, one was messenger RNA, and he was more referring to the individualized part of that, but the principle is more or less the same. So I mean, the answer is we are already invested. Then, of course, Stefan Brock presented before molecular health, which is more the integration and contextualization of the clinical, the molecular information to build individual, I mean, really personalized disease models, and then with the understanding of the mechanism of action of the drugs to see which kind of combinations actually, which kind of combinations you should apply for that respective patient. And I think the promise behind this is not only a personalized treatment with a much higher effectiveness in particular first line and all line treatment, but also by following up the tumor's escape under treatment pressure to allow to follow the tumor, so to say, where he escapes to, and then to always, hopefully always have therapies available for that situation. I mean, the analogy comes from, obviously from AIDS, where AIDS is not necessarily a deadly disease anymore, and it's the same principle. You profile the situation, and you do the same over here. So this is another company we are invested. But I mean, to come back to your question, what I would definitely invest to right now, if there was a concrete business model, and Omar, we talked about this is a whole microbiome space. I mean, I'm absolutely convinced, and I think it didn't need this conference, but the conference further underlined that the microbiome of the colon and possibly not only the colon, that this plays a very important role in the disease. And I mean, we know other areas. I mean, Harald Zuhausen is a prominent representative for this with a Nobel Prize here in ovarian cancer, and I think that the interaction between cancer and viruses or bacteria or whatever the microbiome at the end includes, I think this is another very important field for the future, which has been under, I wouldn't say it wasn't seen, but I think it starts to become more and more obvious. And in that regard, I was almost shocked when I saw that Novartis and GlaxoSmithKline exchanged their divisions, namely GlaxoSmithKline gave away oncology to Novartis, and Novartis gave away infectiology to GlaxoSmithKline, because I think these are not diverging, I believe these are converging areas. Again, Daniel Vasella is not around anymore. One has to talk to his successor and tell him that this was not a good idea. He can kick me out again. I don't mind, but I believe this will converge in the future. So I think this is the area where we would look at from this conference.
Yes, Professor Hallek, if you are reading the newspaper last 2 or 3 weeks, early detection was under fire. So a lot, the Bundesärztekammer and a lot of people have said that there's a better development, breast cancer, PSA and prostate cancer, and so are under discussion. Is that also a problem for colon cancer?
It's a very good question, and actually I would have said it anyway. I think this discussion is needed, and I also think that for reasons that have been established in this country by your foundation, colorectal cancer is one of the very few examples where preventive medical measures, I'm not talking about prevention by nutrition and all these things, is well established and is not a question anymore, except for some methodological questions eventually. If you now look for skin cancer, if you look for breast cancer, if you look for any other method, we have believed that it's a well-established fact, and actually also the German Cancer Aid, the Krebshilfe, everybody. But if you look meticulously at the available evidence, this is not so clear, especially in breast cancer. The dogma is actually shaken. That's not the case, and I should emphasize this. All data that I know and everything that I see is clearly indicating that early colonoscopy or intervention in colorectal cancer, probably because you remove what is at risk, is a clear evidence-based thing at the moment. And I think that's important to make this statement. But I do agree with the discussion, albeit it may sound unexpected that the Bundesärztekammer in Montgomery is raising this point, but in essence he is right to raise the point. It's not a totally clear field.
Otmar, what's your...
I agree. I mean, there is many questions open. The interesting issue is, what is the reason for this? Are the technologies not adequate? Quality control is certainly an issue in mammography. In particular, do we really have the right tools? In the case of PSA, which is a heavy discussion here also among our epidemiologists, I think PSA is just useless as a screening tool. So we must find better biomarkers. And from an evidence-based point of view, I agree. This issue needs to be put on the table. What I'm a bit concerned about is, you know, in Germany we have a society which is quite skeptical towards new sort of developments. And all the discussion now about mammography, about PSA screening will hopefully not interfere with all these sort of initiatives for colorectal cancer prevention. I mean, there's another area where we have a lot of concern, Harald in particular, and that is papillomavirus vaccination. We have a fantastic tool for cancer prevention, the best one which ever probably came out of Germany, a vaccine against the carcinogenic papillomaviruses. There is clear evidence now from studies that you can significantly reduce the incidence of precursor lesions. The reduction of cancer can still not be demonstrated. That requires a 20-year follow-up. Yet, you know, Germany is among the countries which have the lowest vaccination rates among girls. And again, this reflects some kind of basic sort of skepticism. So I fully agree, we must have this discussion. It must be evidence-based. We should go through it fast, because the longer it takes and the more this is being taken up by the media, the greater my concern would be that this will also harm early detection in areas which are not really questionable, such as colorectal screening.
Because it's a real discussion, I try to be short, but it's an interesting thing eventually. Again, we do agree, and there's two things maybe to be added, and as a strategy for the future first. So what we are thinking in Cologne with Rita Schmutzler and others to get to a targeted prevention, so that we identify populations at risk. In the future, it might be genetic. It is certainly by the history of the patient. If we have data, let's say mining strategies from healthcare files, we can also identify patients that are at risk. And so that the screening for breast cancer in the future, as an example, could be on targeted populations to enrich for risk patients where it makes much more sense. So that could be one strategy for the future. Mm-hmm. And second, and just as a point to be honest about this, I mean, I was always doubting, and I'm still doubting, and the dermatologists will kill me for what I'm saying now. You know, of course, it's also in the self-interest of the medical profession to do prevention. If you say, well, I need to see the patient every year to do prophylactic investigations on the skin in total after, let's say, 40 years of age. So that we always have to weigh how the incentives are set in the system, and whether they really are to the benefit of the patient. And we need to be honest about this. If that is avoiding skin cancer, I'm 100% positive and supportive of doing these examinations, and yet it can also have a much simpler purpose, and that's feeding the profession. And therefore, I think we need to be open in these discussions, to be honest, and to be really meticulously correct in our analysis on the data. And that is for this purpose, I think it's good that the medical profession itself starts this discussion and not from outside. We have done so many mistakes recently in other areas that it's good to be honest about things when it comes to patient care.
Mr. Eberhardt, can I? Yeah, I'm coming to you. Is SAP offering some early detections to the co-workers? Yeah, okay.
Thank you very much. Yeah, I was about to mention that. And from my perspective, there are two aspects to the discussion. I think I would wholeheartedly agree that this discussion about the value of these, preventive techniques is very, very important, because we need to have that discussion, especially also in Germany, about the ability to use the data. And there are two dimensions to it. Number one, there's a technical dimension, and there's the permission. And hopefully, this discussion will also give us the opportunity to basically then open up to some extent, see that we can really generate value from, analyzing the data, looking at the data, and really come up with better predictions. I give you an example. Again, this week we had our big event in Orlando, and please forgive me for the example, but John Deere was on stage showing what they can do with the technology, just looking at the diagnostic data that is available to them in real time. They are able to really predict, at which point in time they will see failures of, their device. Again, much simpler, very different case. But I just want to highlight that other industries, because the technical ability is there, they don't have any permission problems, obviously, right? So with that, they can analyze huge amounts of data, can do the root cause analysis much more proactively, and hopefully we can, in a year or two from now, we can showcase some examples where, based on the data that we have, we're able to look at and analyze. We maybe find out, look, in a case of mammography, this was kind of the root cause why we have been as good as we wanted to be with our programs.
Okay. Yeah.
And let me add another aspect here, which was kind of yesterday we announced this, Werner and also Otmar. I think another way to deal with these kind of data and to bring that here into the broader awareness and have a different inbound route into both awareness but also payer systems was an idea that SAP and we created, and I mean also together with here DKFZ, but not exclusively, is to create a program. We call that COPE. COPE stands for Corporate Oncology Program for Employees. This comes in analogy to the self-employed systems that American companies have, actually, namely, I don't need to explain this, but the idea is that a company like SAP, and SAP is the first company now who does it, will offer from his human resource department for every employee in the company who has cancer or who will get cancer on a volunteer basis, because no one has to say he or she has cancer, a program where you say, if you are diagnosed with cancer, I mean, on the cost of the company, we bring you to this personalized diagnostic system. I mean, in Germany, here through Molecular Health, GATC, NCT, in the United States through other partners. I mean, these are the two countries we start with. And I mean, if you look to the cases, I mean, if you assume, and Otmar and Professor Hallek, please correct me if I'm wrong, because I'm not an oncologist, but if you assume that 3% of all employees do have cancer, in a 60,000 employee company, this means 1,800 people do have cancer. And if you think that 0.5% get cancer every year, this is unfortunately 300 employees or one employee per day who gets cancer. And I think if employers, I mean, are supporting this and then combine that, Frau Ma, also with prevention measures, yeah, hopefully, then I think there can be a complete different both awareness creation, data generation here for the whole health system, because I think these data should not be owned by someone. They should be, so to say, available for whoever wants to help and cure. And I think it can also possibly help in Germany and in the US, and both systems are difficult in reimbursement. I mean, I can tell you, we know both systems and both are difficult, and I don't want to talk about the difficulties here because I think almost everyone is aware, but I think it can help here to possibly overcome barriers and tediousness, because at the very end you don't need to be too intelligent, yeah, that it will pay off if insurers, so to say, invest into prevention and programs that help to early identify and early treat cancer. And I think this is another program here that we see as a kick-off program. And let me also say this, Werner, I mean, part of our technology runs on your HANA technology, and the idea is that more of the technology will run on this. And this is also, I mean, it's an example not only for, I think, a smart collaboration for those people in companies who get cancer. It is also, I think, a showcase here for German technology and German centers. You know, the network idea, Otmar, that you created, that we can do good things and don't need to be MD Anderson or NCI.
Thanks. We have promised to stop clearly before 5 o'clock, so maybe we can have a last round of one question. Professor Hallek, is there a take-home message regarding prevention? What should I do? Should I take aspirin, or what is your recommendation?
Yeah, that's actually the major question I get from patients all the time. My recommendation is live reasonable, try to be healthy and happy. I try to be happy and do things that you enjoy. And usually any medical prevention, things that doctors do, is usually not so important as anything that you do for your life yourself, like doing sports, running, eating reasonably, try to control your weight, and eventually do one colonoscopy after the age of 50, 55. That's actually the only thing. And all the rest I'm not recommending, because I think patients should see their doctors only if they are really sick, and for some preventions that are for children and so on that are of course reasonable. And this is my advice for prevention as of 2014.
Maybe this is the best closing remark. Be happy. But maybe everybody wants to say something. You have a recommendation in the SAP company. You recommended to take aspirin to your cookbooks, or what you are doing? Nothing.
I can only echo what just has been said. So okay. we just launched an employee health support program, which basically does what you just explained. So we work with an external partner to basically support our employees with modern technology, but also with simple things like, you know, watching their weight, the waist size, whatever, to basically live healthy, live happy. Very important aspect. So I can only echo what you said. And in addition, obviously, the COPE program is an important pillar for us as well, because not only helps it with those individual cases, and I know a number of them personally, which is every single life is so important to have in these individual cases, but also to raise the awareness and spearhead the effort, what we can do with smarter decision making, with support of technology, beat sequencing, but also the IT technology. So nothing to add from my perspective.
Mr. Bohlen, what is your recommendation?
Keep it very short. I only want to second what you said. I was in a school, and in that school, I mean, the Leitspruch of that school was mens sana in corpore sano. I think this says everything. I mean, that school, so to say, summarized what, you know, this is obviously not from me or from that school, but I can only say the same, and of course, but I'm preaching to the converted here. I mean, everyone in my family, I mean, my parent family was a smoker. Yeah, I mean, this is definitely also not a very good idea, I would say. So, but actually, I mean, as everything in life, I mean, keep everything in measure. I think movement is important. I think every doctor would support. So keep yourself a bit, you know, sportive in some way. But unfortunately, at the very end, in cancer, you need a little luck as well. And I wish everyone that little luck not only in this room here.
Well, what has been said. My advice to the medical community is what we discussed. We must provide evidence for early detection and prevention tools and implement them in a consequent sort of fashion. That's number one. Number two, for the research community, the cancer research and oncology community in particular, we must seriously invest in preventive oncology. This area is underdeveloped and requires more attention. Now, to the public, we have our 10 rules to decrease your individual risk of cancer development. These are adapted to Paul Clay, who came up with them at the IARC years ago. The first 3 are don't smoke. Then some of the well-known ones, balance your nutrition and your weight, keep your body moving, avoid heavy sun exposure, participate in quality-controlled early detection programs. Michael Hallek alluded to that already. Make use of preventive vaccinations. Papillomavirus, hepatitis, for instance, that is often forgotten. And I have to agree with Friedrich. In the very end, you also need a certain dose of luck. That's about what you can do.
What is with wine?
Oh, I don't want to
Red wine. Okay.
There's so many publications on that. Okay. But I avoided it, as you may have heard.
I thank you very much for joining this panel discussion once more. Kasama, thank you very much. We have the best. We have the best take-home message, be happy. So that's absolutely great. I wish you a safe trip back and hope to see you maybe next year.
I have to discuss it with the gentleman on your right-hand side.
Okay.
We try. We try.
I will give my best to convince you. Thank you very much for staying with us.